Yeah, just now become live. Okay, right. Right. To start, proton pump blocker should be taken minimum with the two antibiotic for treatment against infection, and treatment should be minimum 7 days, maximum 14 days. And proton pump blocker may cause B12 deficiency, but for H. pylori we give only for 2 weeks. In this 2 week therapy, they don't cause B12 deficiency, so it is false statement. And patient recurring, actually, what Goodman Gilman says, look here, chronic therapy with the proton pump blocker will decreases absorption B12. So it's seen only on chronic therapy, not on 2 week therapy. And then patient recurring long-term NSAID should undergo H. pylori eradication therapy to reduce ulcer risk. Yes, true statement. Because in Goodman Gilman book, it clearly mentioned patients who have lymphoma in the stomach or chronic atrophic gastritis or though having intestinal metaplasia or dysplasia or patient on NSAID, they are prone for H. pylori infection. So for them, better to give H. pylori therapy. So find out the correct response mean 1, 2, 4, correct. The answer is option number B. Option number B. Okay. Now look at the second question. Poorly absorbed antibiotic. See, poorly absorbed antibiotic often used as a adjuvant therapy in patients with the hepatic encephalopathy. This may include what? Tenofovir, tenofovir. They're all mainly useful for a hepatitis B virus infection. They're antiviral. There's not antibiotic. Sofosbuvir and Belpatazine. They're mainly useful for hepatitis C virus infection. They're not antibiotic. Levofloxacin antibiotic, but they're well absorbed. They're well absorbed from intestine, so they're not the answer. So answer should be neomycin and rifaximin. Neomycin actually aminoglycoside. You know, aminoglycosides are not absorbed from GAT because all are ionized molecule. For a drug to get absorption, it should be non-ionized. So neomycin, a aminoglycoside, not absorbed but stays in the intestinal lumen, useful for hepatic encephalopathy. Rifaximin, a rifampicin derivative, that's also not absorbed, useful for this case. Actually, what happens in hepatic encephalopathy? Actually, these two drugs acting on intestine, they're not absorbed, acting on intestine. In the intestine, they control some gram-negative infection, thereby inhibiting conversion of urea into ammonia. Urea being ammonia by urease enzyme. This enzyme activated in the presence of gram-negative infection. So these drugs are able to attack the organism, thereby inhibiting intestinal ammonia production, thereby useful for treatment of hepatic encephalopathy. Okay, and one thing, the neomycin rifaximin. I just want to tell extra point. The extra points are rifaximin, a wonderful drug for so many GI infections. For example, useful for inflammatory irritable bowel syndrome, traveler's diarrhea for 14 days. Yes, minimum 7 days, maximum 14 days must give proton block. Yes, good, Rajat, good. Now, rifaximin useful for traveler's diarrhea. It is caused by enterotoxigenic E. coli and also useful for hepatic encephalopathy and for pseudomyelitis. Whereas coming to neomycin, yeah, aminoglycoside, it is actually very toxic. When used systemically, it will cause severe nephrotoxicity, severe skeletal relaxation. So neomycin used only topically, but can be used orally because it not getting systemic absorption, useful for gut sterilization and for hepatic encephalopathy and for E. coli diarrhea. So answer for question option D. Okay, option D. Yes, yes. Actually, proton pump blocker causing B12 deficiency, I do agree, Rajat, but it occur usually on chronic therapy, not on acute therapy. That's why I mentioned wrong. Okay, so Rajat, that because of Goodman-Gilman clearly mentioned it occur only on chronic therapy, not on acute therapy. That's all. Okay. Now coming to question number 3, very simple state question: which of the following is an oral anticoagulant? Very simple question. Okay. Dabigatran, heparin, fondaparinus, beurudin. Straight question. Dabigatran, a oral direct thrombin blocker. So direct to it. Direct thrombin blocker. Oral drug. Oral drug. And one second. Can anybody answer? Come on. Mandira Paul. Rajat, can you answer? It's a fantastic oral anticoagulant. A direct thrombin blocker. Can you answer? What is the antidote for this drug? The action of this drug reversed by, okay, the action of this drug can be reversed by what drug? It is idarucizumab. Dabigatran, a oral anticoagulant. Its action can be reversed by idarucizumab. And heparin injectable, fondaparinus injectable, beurudin. It is also injectable drug. It's an injectable direct thrombin inhibitor. For example, in the injection category, we have bivalent and monovalent. Example for bivalent drugs are we having herodin, Bolrodin, Leprodin. Yes, good, good. All are answering very nicely. Edaru, system very fantastic. Good. Now listen. Injectable direct thrombin blocker. We having herodin, Bolrodin, Leprodin. Monovalent drugs are argatroban, malacatam. All these are injectable direct thrombin inhibitors. So, answer for this question option A, dabigatran, a orally given anticoagulant. An extra point, remember, among this injectable to a blocker, argatroban undergo excretion bile. So, it is safe in kidney failure. All other drugs undergo renal route unsafe in kidney failure. This is also important point. Keep in mind. And this revision to recall your UPSC answer are also very useful for near coming NEET PG exam. So look at the options and explanation. Which of following glucose lowering agent can be given as an injectable drug? Injection. The right answer for this question: pyrrolidine oral, metformin oral, sitagliptin oral. Answer semaglutide. One. Actually, all the glutide, for example, liraglutide, semaglutide, all are GLP-1 analog. You know, GLP mean gluconolate peptide cannot be used orally, so they are given only injection subcutaneous route. Okay, so question here I just want to know, in general, what are all the injectable anti-diabetic drugs we have? In general, the injectable anti-diabetic drugs mean one very well known insulin. Next is pramlintide. Pramlintide, a islets amylin. It's a amylin polypeptide. Since peptide, it is also injection. One is insulin, made up of amino acid, and pramlintide. Then all the GLP-1 analog like liraglutide, semaglutide, all the glutide. And two important new point you should know: tirzepatide. Tirzepatide. It's a newer drug called dual agonist. What do you? That is, it's a GIP plus GLP. GIP means glucose dependent insulinotropic polypeptide plus GLP, gluconolipid. It is also given as a all these are given subcutaneous injection. Okay, and extra point, the tirzepatide not only for diabetes also got approval for treatment of obesity. Even liraglutide and liraglutide and semaglutide, these also got approval for treatment of obesity. So anti-diabetic drug approved for treatment of obesity are GLP-1 analog like semaglutide, liraglutide, and one more thing, tirzepatide. It's also got approval for treatment of obesity. An extra point actor, we have one thing called teplizumab, a monoclonal antibody approved for type 1 diabetes. Actually, in type 1 diabetes, the stage in a type 1 diabetic stage 2, in stage 2 patient, to prevent the progression of stage 2 into stage 3, we give one drug called teplizumab. It's an intravenous infusion IV anti-diabetic drug targeting against CD3. It is given for 14 days therapy to prevent the conversion of stage 2 type 1 diabetes into stage 3. So new point, teplizumab. And extra one point, look here, in your UPSC question, they're asking semaglutide. But this drug among the GLP, it's the only one can be used orally also. So question, all the GLP-1 analogs are given injection subcutaneous. The semaglutide can be, even though GLP can be used orally also. That's about important point. Option A, B, C, all are orally given anti-diabetic agents. So I think this will be very useful for you. Some new point. So what are the injectable anti-diabetic and which is given IV? Come among the insulin, regular insulin can be used IV for treatment of diabetic ketoacidosis and for treatment of hyperkalemia. That you know. One new point, teplizumab IV infusion for 14 days in type 1 diabetes to prevent the progression of stage 2 to stage 3. Of course, one last point, the insulin and pramlin, these two drugs got approval for treatment of both the type 1 and type 2 diabetes. So name some anti-diabetic approved for both type 1 and type 2 mean one is insulin, second is pramlin type. Okay, coming to question number 5. Which of following is an inhibitor of the intestinal mucosal transporter NPC1, Niemann-Pick C1L1, response for absorption of dietary biliary cholesterol? Very simple straight question. The drug inhibiting NPC1, thereby inhibiting cholesterol absorption is ezetimibe. So look here, ezetimibe, a cholesterol drug. I'll explain. Look here. Imagine it is intestine. Okay, a patient taking cholesterol diet. The diet goes to GAT. I just opened the GAT. Now the cholesterol goes inside the intestine. From the intestine, the cholesterol getting absorption. The absorption done by one transporter called NPC1, that is Niemann-Pick C1L1. This transport can be blocked by one drug called ezetimibe. So ezetimibe inhibiting cholesterol absorption from intestine by inhibiting NPC1L1, Niemann-Pick C1L1 transporter. Okay, that's about this one. Okay, and next question, look at the option. Metformin is not a cholesterol drug, it's an anti-diabetic insulin sensitization. Favored a cholesterol drug but acting as a PPAR alpha agonist, thereby activating lipoprotein lipase. By activating lipase, they will decreasing triglycerides, so-called VLDL. So question, for treatment of hypertriglyceridemia, the best answer go for 5 grades, the PPAR alpha agonist. Coming to atorvastatin, very special. Statins are wonderful cholesterol lowering drug acting by inhibiting HMG-CoA rectase. Okay, statin inhibiting HMG-CoA rectase it is a rate limiting enzyme in the synthesis of cholesterol. By inhibiting this enzyme, they ultimately inhibiting cholesterol synthesis. It's one mechanism. The second mechanism, second mechanism causes upregulation of LDL receptor on liver cells. By causing upregulation of LDL receptor on liver cells, they causes engulfing all the LDL. Now LDL are taken into liver cells, thereby plasma LDL also get decays. So statin doing a very good job, that is reducing total cholesterol and decreasing LDL cholesterol by 2 mechanisms. total cholesterol decreased because of inhibiting HMG co-reactase and LDL decreased because of upregulation of LDL receptor. So by the way, we done statin mechanism action everything. Okay. So all the 4 options discussed, answer for the question option number D. Right. Now coming to question number 6. Ready? A patient developed difficulty in sitting from sitting position and difficulty in walking up steps and squatting and lifting arms overhead. That means is not able to walk, not able to stand, not able to lift hand. That means all the proximal muscle are getting weakened. That means myopathy, proximal myopathy. So question, chronic therapy of which of following likely to result such a presentation? Okay, yeah. Maximum question from DVT. Yeah, very good, Shivakumar. Fantastic. Good. Thank you. Now look here. When you talk about this, which is the group of drug among these options causing myopathy? The answer is steroid. Steroid causes adverse effect myopathy, thereby problem of standing a position, squatting position, all this thing. Okay. Acetaminophen we call paracetamol. Paracetamol high dose causing only hepatotoxicity, not this one. And fexaventin, antihistamine may cause drowsiness. Metformin, antidiabetic, that going to cause only GI problem. They cause GI problem like indigestion, diarrhea, nausea, and also causing B12 deficiency. And rarely in a kidney failure patient, it may cause rarely lactic acidosis. So answer for the question option C. Coming to question 7, I think straight question. Come on. Hemorrhagic cystitis is the serious adverse effect of what? Rajat, come on. Shivakumar, Aboli, Chavan. Can answer? Pratibha, come on. Hemorrhagic cystitis is straight question. It's a problem of cyclophosphamide. Okay. And for NEET paper also, remember this important point. NEET paper also, for example, look here. Cyclophosphamide, a alkylating anti-cancer drug, may cause adverse effect of cystitis because of forming one thing called acrolein. Cyclophosphamide produces one metabolite called acrolein. This may cause cystitis. And for treating this, we have an antidote. Anybody name the antidote for this case? Answer, Mesna. Fantastic. Mercaptoethane sulfonic acid can be used IV or oral. That's a specific antidote for cyclophosphamide. Very fantastic, man. You're rocking the show. Fantastic. Okay. Leflunomide, a DMOD, a disease-modifying anti-rheumatoid drug, mainly causing adverse effect of hepatotoxicity. Mycophenolate, a anti-metabolites, mainly causing immunosuppression, causing infection. Being an anti-metabolic causes myelosuppression adverse effects. Methotrexate, again a DMOD. As a DMOD, we use low dose chronic therapy causing adverse effect of hepatotoxicity. But you must also know methotrexate acting as an anti-cancer drug of choice for choriocarcinoma. In this case, we give high dose. When you give high dose, risk of myelosuppression, alopecia, GI damage, as well as risk of kidney problem like forming crystals, all these things, So question, as a DMOD, we give low dose chronic therapy causing adverse effect of hepatotoxicity. Coming to question number 8. Ready? Very simple straight question. I think this is very easy question in UPSC regarding pharmacology. Which of following are the correct statement regarding acetaminophen? Acetaminophen, I mean paracetamol. What are the true statement? It does not interfere with platelet. Yes, paracetamol has no anti-platelet action. Among the NSAID, the only one drug having anti-platelet action is aspirin. So it is true, not a and. It is toxic to liver and heart. Yes, definitely toxic. True statement. And it is not a non-narcotic. Yeah, true. It is not non-narcotic. Narcotic means morphine. So non-narcotic. NSAID is called non-narcotic. So I think correct statement all. 1, 2, 3. All are correct statement. All good. So here, just for pharmacology, just for NEET paper, just go through. This is important question. Acetaminophen, also called paracetamol, undergo phase 1 reaction by CYP2A1 enzyme. Name the microsomal enzyme involved in phase 1 reaction CYP2M. Thereby, they are going to form one metabolite called NAPQI called N-acetyl para-benzoquinoamine. They form one thing called N-acetyl para-benzoquinoamine. This metabolite causes adverse effect of hepatotoxicity. But we don't actually in normal dose we don't develop this problem because this metabolite further undergo phase 2 reaction and going to form a non-toxic compound. This phase 2 done by glutathione conjugation thereby become non-toxic, become inactivated. Now the point, suppose a patient taken overdose, say 10 gram of paracetamol. Normally per day it should be less than 4. The maximum dose per day should be less than 4 gram. Paracetamol maximum dose should be less than 4. They take more than 10 gram as a single dose. There's a high risk of hepatotoxicity. In this case, can you please answer? To control the hepatotoxicity, I have an antidote for paracetamol. Who is that? That is N-acetylcysteine. It is acting as a glutathione gyrate. So the specific antidote for paracetamol N-acetylcysteine. As early as possible, if we give this antidote, we can very well control the hepatotoxicity. If not, I have one thing called methionine. Methionine is also an alternative antidote for paracetamol, but comparing to N-acetylcysteine, methionine having less efficacy, but can be useful. Okay, one more thing, remember, the CYP2E1 may be induced by something called isoniazid and chronic alcoholism. The chronic alcoholism, isoniazid CYP2E1 inducer. So, when paracetamol taken with the isoniazid will induce this enzyme, thereby paracetamol rapidly going to form hepatotoxic metabolite. So, combination of paracetamol ion is causing high risk of hepatotoxicity. In chronic alcoholic, paracetamol causing high risk of hepatotoxicity. All are very interesting question. You could keep in mind. Okay, and then now we on to question 9. Ready? Poisoning with which of following drug causes hypothermia? Any idea? Poisoning with which of following drug causing hypothermia? Digoxin, chlorpromazine, iron, and alcohol. See, doctor, alcohol has problem of cutaneous vasodilation. By causing vasodilation, they will all the heat will goes out of body. When heat goes out of body, they go for hypothermia. So alcohol causing hypothermia. That's why in a cold climate, somebody taking alcohol are more prone for hypothermia because in cold climate the body want warmth. Though naturally they go for vasodilation. Alcohol causing vasodilation, that way all the heat will be evaporated, so body go for severe hypothermia, dangerous. That's why alcohol unsafe in cold climate. Keep in mind. Okay. And then, which of following are selective serotonin reuptake inhibitor? I got an option. Select the correct answer using the code, right? Yeah. S7, yes, true statement. Amitriptyline false, it's a TCA. It's a TCA. Fluoxetine, yes, true. Certain true. That means 134. 134. That means you should know it's simply a classification based question. Come on. SSRI and TCA. Look at amitriptyline, one of the tricyclic antibiotics. For example, when you say TCA, the important drugs are we have clomipramine, doxycycline, imipramine, amitriptyline, nortriptyline, desipramine, amoxicillin, meprotylene, and riboxidine. All are example for TCA. TCA. Whereas asking which are the selective serotonin reuptake blocker, SSRI. The example for SSRIs are we having fluoxetine, fluoxamine, fluoxamine, paroxetine, citalopram, S-citalopram, sertraline, ortioxetine, and dapaxetine. All are SSRI. So, S-citalopram, fluoxetine, sertraline, all comes under SSRI. So, answer for question option number C. Okay. Which of following are classified as a mood stabilizing psychotropic agent? Mood stabilizer. Lithium, valproate, lamotrigine. Yeah, lithium is a very fantastic drug of choice in bipolar disorder to prevent mood fluctuation. We will know. And lamotrigine and valproate are anti-epileptic. Remember, among the anti-epileptic, we have three important drugs as a mood stabilizer. One is carbamazepine, then valproate, and lamotrigine. So they are mood stabilizer. That means answer is all. 1, 2, 3. All are mood stabilizer. Okay, good. Now, question 11. Ready? Good. All are answering nicely, man. Good, good, good. Right. A 50-year-old male diabetic patient with recurrent episodes of hypoglycemia. On examination, pulse around 84, BP around 160, and CVS was no problem. Which of the following anti-hypertension should be avoided in this patient? The case of hypertension with diabetes. In this case, which of the following anti-hypertensive should be avoided? Very straight question. Non-selective beta blockers are not good in diabetic because they causes one thing, hypoglycemia. Point 2, they cause masking symptoms of hypoglycemia, and they also delay the recovery of hypoglycemia. Because all these reasons, non-selective beta blocker not good. That's why in our regular class we tell you hypertension with the diabetes mean always the first line choice should be go for ACE-inhibitor or ARB or CCB. So for treatment of hypertension with diabetes, always go for either ACE-inhibitor or ARB the first choice, or else we go for CCB. But better avoid non-selective beta blocker and thiazide additive. Avoid thiazide diuretic because they cause hyperglycemia, and beta blocker they will mask all the symptoms. They may cause hypoglycemia. They will delay the recovery of hypoglycemia. So they are not good. Okay. Now look at the other option. Tell me Satam. It's a ARB having PPAR gamma agonistic action. That means insulin sensitizing property. It is very well able to control diabetes. So the best drug. Torsemide, amlodipine, they don't cause any much problem on this case. So here best to think single response question avoid non-selective beta blocker. Question number 12. A 13-year-old female presenting with a severe autoimmune hemolytic anemia. Which of the following should be the initial step in the treatment of this case? Autoimmune hemolytic. That means autoimmune disorder. Usually for autoimmune disorder, the first therapy should be steroid. Steroids are first. So look option here. Answer A, prednisone. That's the best. So for all cases, or when go for steroids. If the response is good, maintain. If there is no response or poor response, then we can go for rituximab, a drug targeting against C20 can be tried. Or we can try other immunomodulator or plasmapheresis, or at the end we can also go for emergency spending. But usually as an initial therapy, better go for steroid. So answer option number A. Coming to question number 13. Which of following is the most appropriate initial treatment in the management of severe hypercalcemia? Most appropriate initial treatment. I'm asking first treatment in the treatment of hypercalcemia. Intravenous infusion of pamidronate, oral phosphate, supplementation of IV fluid, and hemodialysis. Come on, Mandira, Swati, Backham, Aboli, what you made answer in your exam? Can you please answer? For this question, what your answer? See, the first therapy should be IV fluid therapy. Hydration. So what Goodman Gilman mentioning, for treatment of hypercalcemia, look at this. Usually for treatment of hypercalcemia, the first step should be maintain good hydration, give IV fluid, and then go for loop diuretic. Loop diuretic loses calcium in urine. They cause calciuria, so they can be useful for treatment of hypercalcemia. So question, first thing IV fluid and then diuretic. Whereas today the drug of choice, suppose asking drug of choice today, the drug of choice for hypercalcemia go for bisphosphonates. They are the drug of choice. For example, we can go for IV pamidronate or IV zoledronate. They are the best drug of choice. Drug of choice. Whereas one more question, we have something called hormone like calcitonin. This drug, a fastest acting drug, rapidly reducing serum calcium level. So calcitonin, a hormone from parafollicular C cells of the thyroid, have fastest answer, rapidly decreasing calcium. And plecamycin, mithramycin, they're all antibiotic, anti-cancer drug useful for treatment of hypercalcemia. Of course, last option we can try hemodialysis also we can try. So coming to your UPSC question, look at the question. For the treatment of hypercalcemia, initial therapy, I go for IV fluid therapy, answer C. But the drug of choice means we go for bisphosphonate. Phosphate, once upon a time we tried, but not now. Dialysis can be useful, but not first. Okay, so answer is option number C. Coming to question 14. Which of following are used in the management of hyperkalemia? This type of questions are we discuss in NEET one question, 10 seconds, EQ. So we 10 minutes discussion, one question. No? In that series, we discuss all this question. I think when I see a question, I myself feel happy because same question come in examination. Okay, which of following are used in the management of hyperkalemia? Which are useful? Multi-response. Calcium gluconate, yes, true statement to control cardiovascular. IV insulin, yes, good to control potassium, good. Hypertrophy, no. Hypertrophy has no role in this case. But we can try beta 2. Beta 2 again is like salbutamol. They can be useful, but not anticoagulants. And IV sodium bicarbonate, yes, we can give. So the answers are 1, 3, 4. That 1, 2, 4. 1 to 4. Answer B. Very good. Answer 1, 2. But in this junction, please keep in mind, it may be important even for your near coming NEET paper. For example, if they ask him hyperkalemia, in hyperkalemia, one of the dangerous problem, risk of cardiac arrest, arrhythmia and cardiac arrest. So here the first treatment should be prevent the heart problem by injecting calcium gluconate. 10 ml, 10% calcium gluconate in a 3 to 4 ml of calcium. Okay, 10 ml of 10% calcium gluconate is the drug of choice for control of cardiotoxicity. Okay, and then for controlling potassium, what is choice? For controlling cardiac problem, drug of choice means calcium gluconate. Okay, whereas for controlling potassium, for rapid, normally potassium 3.5 to 5.5 milliequivalent. More than 5.5, we call hyperkalemia. For rapid control of potassium, the drug of choice will be regular insulin, intravenous regular insulin, 10 units of IV regular insulin. But when you give this, risk of hypoglycemia, so followed by this, you have to give glucose infusion. So IV regular insulin and dextrose intravenous infusion is the first line choice for controlling potassium. And along with that, we can supplement beta 2 agonists like salbutamol. Fantastic. It's also going to push us the plasma potassium into cellular compartment. Okay. Similarly, today you should know one new point. We have something called potassium binder. We can remove the potassium from the intestine using something called potassium binders. For example, we have sodium polystyrene sulfonate. It's a binder and going to excrete the potassium through feces, but causing adverse effect of severe intestine necrosis. Be careful. And other example for potassium binders are we have patiromer. One more thing called sodium zirconium cyclosilicate. All are potassium binder, useful to remove the potassium through feces. If not, we can try some diuretic like loop diuretic. Thiazide, they also going to lose potassium in urine, or we can try hemodialysis. These are the options available for treatment of hyperkalemia. In your question, to control the cardiotoxicity, the best is go for calcium gluconate, and to control the potassium, go for IV regular insulin, and no role for hypertrophy. We can give beta agonist, no role for anticoagulants. So answer option number B for this question. Yeah. Now, question 15. Ready? Consider the following statement regarding organophosphate induced delayed polyneuropathy. Organophosphate induced delayed neuropathy. Right? It's a rare complication occur 2 to 3 weeks after exposure. Yes, that's why delayed true statement, rare complication. It is a future of poisoning with certain organophosphorus like triorthocrysyl phosphate. Yes, true statement. Inhibition of acetylcholinesterase. No. The delayed polyneuropathy is due to inhibition of neuropathy target esterase. We have something called neuropathy. Neuropathy targets esterase enzyme. By inhibiting that enzyme, they are going to cause both sensory and motor neuropathy. It is not because this, so it's a false statement. There's no specific treatment. Yes, for OPC poisoning, we can go for treatment with the atropine, oxime. For neuropathy, there is no specific treatment. Treatment self-limiting, or we do some exercise physiotherapy, it can be overcome. So it is true statement. Whereas this is called false. It's false. So the right answer is 1, 2, 4. That means answer C. Yes, good. Swati Roy, answer C. So remember, delayed polyneuropathy is the problem after 2 to 3 weeks after exposure. Maybe due to certain compound like triorthocrysyl phosphate, and it is due to inhibition of neuropathy target esterase enzyme, and for this there is no specific treatment. So answer option C. Coming to next question, consider the following pairs: urine color and possible causative agent. This may be for some student may be difficult because in our regular class we say rifaximin causing reddish orange color urine and nitrofuranate causing coffee color urine. Like that, but they're asking extra also: pink cephalosporin, brown chloroquine, greenish one benzopyridine, red orange amitriptyline. How many pairs given above are correct batch? Come on, Swati Roy, what's your answer for this question? What you made answer? See, actually, to answer the question, you should know some drug causing some color problem. For example, look at red color. Chlorphosphine. Chlorphosphine, a drug useful for leprosy. It causes skin reddish, black skin pigmentation. So only urine become reddish. And green blue with amitriptyline, and pink with the doxycycline. Reddish orange rifampicin. Yellow B complex. Brown nitrofurantoin chloroquine. So answer for the question: one pair. Answers option A. So brown color urine, so the chloroquine. So please note this, it may be useful, useful. Okay. So here in May 2024, INCT they asked chlorphosphine anti-leprator causing reddish black skin discoloration was asked. And very old question, look here, nitrofurantoin, a drug useful for UTI causing coffee color, brown color urine. And today in UPSC asking chloroquine causing brown color. Okay, so that's about answer. Only one pair is right answer. That's about question number 16. Coming to question 17. Which of following pharmacological agent can be used for treatment of visceral leishmaniasis? That means useful for Kala-Azar. Very simple, straight question in regular class. Even our DVT, we discuss this question. Options are pentavalent antimony, yeah. Sodium stimulant can be useful, yes, true statement. How about it be? Yeah, the drug choice, Indian patient with the colors are drug choice. How about it be? Spiramycin. Spiramycin, a macrolide mainly useful for treatment of toxoplasmosis, that too very safe in pregnancy. So it has no role in this case. So ruled out. Ruled out. Paramycin, yeah, aminoglycosid given IV for treatment of calasm. Remember, doctor, paramycin can be used orally for treatment of amoebiasis. Of course, very safe in pregnancy for giardiasis. So, paramycin, yeah, aminoglycosid orally not absorbed but useful for amoebiasis and for giardiasis. IV for calasm. That means this useful 1 to 4. The main answer B, option B. Okay. And coming to extra question for Kala-Azar. Kala-Azar, India, Bihar is more prevalent for Kala-Azar. For treatment of Kala-Azar for Indian patient, drug of choice treatment for Kala-Azar mean for Indian patient, the first line drug of choice is liposomal intravenous amphotericin B is the choice. The other drug useful for this case are we can go for pentamidine, paramycin, miltefosine, Sirapine. In this, the miltefosine serum, these two drugs are orally given drug. Other three, the first three are intravenous drug. Of course, paramycin special, it's an aminoglycosid useful for Kala-Azar. But overall, for Indian patient, Kala-Azar means the drug I choose think of intravenous liposomal amphotericin B. Okay, coming to question 18. Consider the following statement regarding paracetamol toxicity. Yeah, I think paracetamol, there are two questions in this paper. No? Already one question, now one more question. Look here. Toxicity caused by intermediate reactive. Yes, we have one thing called N-acetyl parabenzoquinone. This metabolite causes adverse effect causing hepatotoxicity. Antidiabetic paracetamol act by replenishing glutathione and should be given to all patients. This is what important. See, the antidote mean we can say N-acetylcysteine and it is acting as a glutathione patient. That's okay. Whether all patients, that's doubt. Because when it's mild toxicity, no need. Symptomatic enough. In severe toxicity, we have to give. So anyway, keep in mind. An intravenous assisting highly efficacious. Yes. When you give as early as possible, when you give very good response, true statement. Methadone may be useful as an alternative, yeah, but less efficacious is a true statement. That means definitely there's 1, 3, 4. 1, 3, 4, definitely true. So look at 1, 3, 4. No, there's 1, no. That means they given 2, 3, 4. That means this also you should include. That means it given all patient to prevent hepatic and so answer is option number D. Go for option D. Okay. No. Consider the following statement regarding paracetamol. Paracetamol producing toxicity because of formation of one intermediate metabolic called NEEPG, and the antidote is acetylcysteine. When you give within 8 hours, very good response. Methadone can be alternative but less efficacy. 1, 3, 4 definitely true. Since options are not there, so we go for 2 also. So 1, 2, 3, 4 all are true for this question. Coming to question 19, super question. Consider the following agent and cardiac adverse effect on overdose. Prolonged period lithium. Yeah, lithium causes SA node dysfunction. That means reducing heart rate. That will be causing bradycardia, heart to block. Also prolonging the heart block mean that is prolonging PR. Heart block mean prolonging PR interval. That's why Goodman-Gilman mentioned lithium contraindicated in 6 sinus syndrome. Remember, it will cause SA nodal dysfunction. 2-point actor, lithium unsafe in pregnancy, unsafe in 6 sinus syndrome. Okay, so it is true statement. Amyloid causing QT, yes, Amiodarone is a class 3 drug. You know all the class 3 drug. We know class 1A drug and class 3 drug having potassium channel blocking property. They may cause adverse effect of QT prolongation. It's a class 3 drug. So definitely causing QT prolongation. So true statement. Kerosene causing what? No, kerosene causes chemical pneumonitis, causing only lung problem, not heart problem. So false statement. False statement. Organophosphorus, no, organophosphorus or choline esterase enzyme inhibitor. They going to accumulate acetylcholine. It causes only bradycardia, not tachycardia. So this is also false statement. The two pairs are right. This and this two. That means two pairs are right. Answer is option number B. Option B. Okay. Right. Now coming to question 20. Which the regard to treatment of thyrotoxicosis of Graves' disease. With regard to treatment for thyrotoxicosis, consider the following statement and tell the correct answer. Propyl thyroxine suitable in breastfeeding patient. Yeah, PTU safe even in first trimester. So definitely safe in breastfeeding. So true statement. Large goiter is an indication for therapy. Yes, true statement. Radioactive. Okay, students told of okay, as early as possible within 4 hours, best not 8. Okay, controversy. Okay, I don't want to have controversy. Anyway, doctor, medicine people told me, yeah, because I as early as possible was mentioned. Exact hour mean will verify, doctor. Yes, Saket Modi, I accept your response. We verify. Okay, and then radiotidine. No, it is radiation unsafe in pregnancy. False statement. Aganositis is a complication of carbamazole. Carbamazole thioamide. All thiamide causing aganositis. True statement. That means correct response are 1, 2, 4. That means answer C. Very fantastic. Very fantastic. Good. All doing very good job. And last one question. Which of the following antidepressant drug acting by inhibition of monoamino oxidase enzyme? One, phenelcin, trialcypramine, do-sol-penmoclomide. What is the answer? Which of the following antidepressant drug acting by inhibiting monoamino oxidase? Phenelcin, a more blocker, this more blocker, this more blocker. 1, 2, 4. The answer is option number B. B. Whereas dosulpine actually called it's dotiapine. It's also called dotiapine. Brand name Prothadone is a tricyclic antidepressant. It's not a MO blocker. When you say MO blocker, look here. MO blocker means we have two types, monoamine A, monoamine B. MO A enzymes are involved in metabolism of norepinephrine serotonin. So the deficiency of norepinephrine is causing depression. So for treating depression, we go for MO A blocker like moclomide and chlorgelin. So MO blocker, moclomide, chlorgelin. MO B enzyme involved in metabolism of dopamine. Dopamine deficiency causing Parkinson. That's why for treating Parkinson, we go for MO blocker like sertraline, rasalin, latest called sulfinamide. Whereas some non-selective MO blockers, we have phenelcin, trialcypramine, isocarboxyl. Phenelcin, trialcypramine, isocarboxyl all are non-selective MO blocker. That means the answer for the question is look at answer is option number 8. Phenelcin, a non-selective MO blocker. Trialcypramine, non-selective MO blocker. Moclomide, MO A blocker. So answer is option B. Dosulpine is a prothadine trend name. It's a tricyclic antidepressant. Okay, that finishes all the most important question. Remaining question something about oral contraceptive pill. I think Dr. Deep Madam was explained about that, and some question already taken by medicine faculty. Some psychiatric question taken by Sachin. So in my real pharmacology question, I covered. I think all the most important question for UPSC I discussed. I think is going to be very useful, not only for recalling the answer and very useful for your near coming NEET PG also. So do well, doctor. Read well. Read well. Oh, that's was question. Okay, Swati, that's also good. Oh, Pima Vans also asked. Fantastic. Pima Vansarin 5:1 inverse second is a fantastic drug approved for Parkinson's disease. Our DVT is like, yeah, good ma. Thank you for recalling this. So all very best. May God bless you. Don't waste time, doctor. Every second is accountable. May God bless you. All the very best. All the best. Thank you. Thank you very much.